Hi guys, so I'm back on YouTube. This is the first video I've put up in like a couple months. Life has been really crazy, really busy, but it feels good to be back on here. So today I'm going to be talking about a day in the life as an RD. For those of you who don't know, an RD stands for Registered Dietitian. I am not a registered dietitian right now, so first I'll talk about the process to becoming a registered dietitian. You need an undergrad degree, so I went to Penn State University and I graduated this past May of 2018, and I got my degree in nutrition and dietetics. While you're in senior year of your undergrad, you prepare for the dietetic internship. You can easily YouTube dietetic internship and a bunch of videos will come up and it'll talk all about the process. Dietetic internship is kind of like a scary word for a lot of nutrition students. It's a big deal. So you go through a matching process. Like I said, senior year of college, you kind of like scope out dietetic internships in all different states. You can move to a different state if you want. If you get accepted into their program, you can do your dietetic internship literally anywhere. Or you could do what I did and you can do the distance internship, which is basically if you don't want to move to another location, you can just kind of, hopefully, fingers crossed, apply to programs that are closer to home, and you can do that internship if you get accepted. But the only thing is, whereas in traditional dietetic internships, once you get accepted, they set up like all your sites for you. So in the dietetic internship, you're usually required to do a food service rotation, a clinical rotation, and a community rotation. And then usually there's like an emphasis. So sometimes you're able to pick your emphasis, or sometimes, like for instance in my program, we have a business and entrepreneurship emphasis. So that's something different. We don't really need to talk about that, but your program has all the sites set up for you, so you know where you're going for clinical, what you're doing for community, and what and where you're going for food service. But with a distance dietetic internship, the student has to find and scope out all of their sites. So that can be a little challenging. So if you're watching this video and you're a student right now, and you're kind of deciding whether you want to do a traditional dietetic internship and just move or go wherever the wind takes you, or if you want to do the distance dietetic internship, which is what I did, at least you kind of have a little general idea of how that works. Now, the process is really confusing, so if anyone has any questions, feel free to absolutely message me or leave a comment below, and I can definitely help you out, because like I said, you can go on YouTube and just type in dietetic internship and literally everyone will tell you it's a crazy process, and the whole matching process, it's match day, it's just a big day in a nutrition student's life, and it could be a good experience or a bad experience, but yeah, so if you have any questions, let me know. Now, the video is called A Day in the Life as an RD, so I'm going to be talking about my experience so far. So like I said, right now I'm in my clinical, so that means I'm in a hospital setting. I have an hour commute there every morning and an hour commute home, so it's a little bit on the road, but I really like the hospital I'm at. I see a lot of different patients every day, and I'm just kind of going to take you through what I do in a day, which is essentially what an actual dietitian does in a day. I'm only in week 5 of week 8 of the clinical rotation, so I'm still learning a lot. I'm learning every day, but I'm going to take you through a day. Okay, so every morning the dietitians go onto the computer and they see who they got consults for. So consults, you can be consulted by nurses. If the nurse thinks there's a problem, nutrition related problem, they'll say, hey, dietitian, can you come assess this patient? You can be consulted if a person's weight, if they gain a lot, if they lose a lot, if they think weight's an issue, anything related to weight, dietitians are consulted. Wound care nurses, so if patients have wounds, open areas, that requires special nutrition care, so the wound care nurses will already probably be treating the wound, but like I said, nutrition plays a role in the healing of wounds and the treatment of wounds. So you can be consulted by them. If family reports like changes in appetite or changes in weight, family plays a big role in, you know, assessing your patient, because you might be able to find things out from them that the patient forgot to tell you or is leaving out for whatever reason. But generally, like, families can't consult you, but the family might tell, like, you while you're in the room that something's up, or they might tell a nurse something who then in turn will tell you that something's up, or the patient themselves. So when we go in and we do assessments, sometimes we just go in to just generally ask them, like, how's your appetite? We give them a little bit of diet education, like a 5-minute quick tips and tricks and stuff like that. But if we pick up on something else, then we would have to do a full assessment on them, and yeah. So after the dietitians kind of like round and figure out like who needs to be assessed that day, I get assigned to my patients. So all the other dietitians, they kind of have like designated floors. So one dietitian will have floor 1 and floor 3 or whatever. But there's a couple dietitians at this hospital that I'm at, and they all are on different floors. So they have their patients from that floor every day that they see. Since I'm the intern, I kind of get a mix of all the patients, all the different floors, which is good because there are different floors. So there's a like orthopedic floor, so patients who just got out of like surgeries for like hip replacements and shoulder replacements and all stuff like that. Then there's the ICU floor, the intensive care unit, and floors like that. So it's good because you'll see different things going on the different floors. So when I get my patients, I could be doing 3 things. I could be doing a full assessment, I could be doing a diet education, or I can be doing like a length of stay. So if a patient is there for like 6 or 7 days, it doesn't matter even if they don't have a nutrition problem, or we weren't consulted for them. If they're there for like a week, we go in and we just see how they are, and assess their appetite and their weights and make sure that nothing's going on, just to be safe since they've been there for a little while. So when you have your patients, you can do multiple things. We do quick little diet educations with them. So if they're on a cardiac diet because they have heart-related issues, we go in, give them some pamphlets, talk about low salt, low fat, increasing fruits and vegetables, all things that you would want to do on a cardiac diet. And that's just a quick little 5-minute education. If they have questions, you answer them, call it a day. But then there are some things that require full assessments, so they're a little longer in length and time, time consuming, a lot more documentation, and some more digging into their report and history and diagnosis and seeing what's going on. So you can do a full assessment a few different ways. If someone has a BMI over 40, that would be obese, we always do a full assessment. If a patient has been in the hospital for 7 days, we do an assessment. just because they've been there for some time. So just to check up, make sure everything's okay. Chances are if they're there for that long, their diet has probably been compromised in some way. Not always, but sometimes. So it's good just to be on top of those more lengthy patients, the ones that are there for a longer amount of time. Oh, and if people have like pressure ulcers, so wounds, all stuff like that, and we get consulted, that would require a full assessment. There are these little like Cardex, like little cards, index cards, and before you go see a patient, there's a lot of things that you have to fill out on that card prior to going into your patient's room, just to make sure you have a general idea of what's going on, their history, you know, just like when you go to the doctor and he or she comes in and kind of already has an idea of what's going on with you. That's what we're doing with our patients beforehand. So we look at weight, height, BMI, any fluctuations in weight, so we'll look at their weight history, their admission diagnosis, so what they came in for, what they were diagnosed with, their past medical history, any surgeries they've had, any food allergies they have. We'll look at their lab values, so a lot of times their lab values will correspond with what diagnosis they have, so it's good to mark down lab values. And then there's a few other things. Oh, and then when I get in the patient's room, we'll talk about their appetite. I'll ask them how much they usually weigh, because I can take that number and then look at their weight history since they've been in the hospital, and seeing if they've lost weight, if they've gained weight. And again, a lot of time the diet is either compromised, so they will have lost or gained weight, which always requires nutritional intervention. For instance, if someone has congestive heart failure and they're usually 150 pounds, but when they're in the hospital, they have, because of the congestive heart failure, they have a lot of edema, which is fluid retention in the body. They might weigh 180 pounds now. So that would require me to have looked in their history, realized they have CHF. The edema would have been noted in the documentation. So when I go into their room and they tell me they usually weigh 150, but I see that they were weighed this morning at 180, I don't automatically freak out and be like, oh my gosh, what have you been eating? You know, because chances are they actually haven't been eating as much, or maybe they're eating the same, but fluid, water, weighs. it can be weighed. So that's added weight put onto your body. So it's not necessarily food, but you have to know their nutritional or their diagnosis before going in, because it makes a big difference in nutrition. So they're all the things that we look at before we go in the patient's room. And then, like I said, when we go in the patient's room, we talk about their appetite, their weights, and if they have any nutrition-related concerns. If anyone ever reports poor intake, so if they're eating less than they usually do, especially compared to at home, or if they have like open areas on the body, so wounds, pressure ulcers, all stuff like that, we usually will offer a supplement. So supplements are also really important in nutrition. There are different supplements to use for different patients and different diseases. Glucerna is one that we use often with diabetics because there is a lower amount of sugar in that supplement. So Glucerna comes in a few flavors. It's just like a milk texture, a little thicker than milk, but we just call it a shake, a nutritional supplemental shake, and it has protein in it also, so it's good for patients who have poor intake and or have poor intake and are a diabetic, because it does have lower sugar levels, so it won't spike their glucose too much. Then we have Ensure. So Ensure also comes in a few different flavors. It's also a shake, and we use this a lot with patients who have cardiac issues. It's higher in sugar, so we wouldn't necessarily use this with a diabetic. Then there's Nepro. So Nepro there's a lot of protein in Nepro, and there's low amounts of sodium, phosphorus, and potassium. So Nepro, if it rings a bell, kind of sounds like nephrology, which studies the kidneys. So with people who have like kidney disease or renal disease, or patients that are on dialysis for kidney disease, it's important that they're resupplemented with extra protein, because when they're on diuretics or when they're on dialysis, the protein and calories, you know, it comes out with the dialysis treatment. So you want to put it back in their bodies to make sure that they're still getting calories and all stuff like that. So, and then obviously with renal disease, you want to watch the amounts of sodium, potassium, and phosphorus in the body, because that's not good for the kidneys when they're not working properly, to be having a lot of those minerals in your body. So this drink is lower in them, so that's why we offer that to them. And then there's Magic Cup. So Magic Cup is like a little ice cream or sherbet supplement. Comes in a few different flavors, has sugar in it and a lot of calories. So again, we wouldn't want to use on a diabetic unless they were really like probably severely malnourished and they didn't like the glucerna. Then I don't know, maybe we would try Magic Cup, but that's reserved for, I guess, more specific situations, not really honing in on like one disease state. So that's there is another option for a supplement. Also, the thing with Magic Cup, I know it's like this at our hospital, I don't know if it's like this everywhere, but if a person is on a fluid restriction, which they may be if they have CHF, if they have kidney disease, all stuff like that, there are different reasons someone might be on a fluid restriction, but if they are, all those other shakes that I mentioned count towards their liquid for the day, and patients usually aren't too happy with that. They'd rather like water or their juices or soda or something to count towards their liquids, because usually when they're on a fluid restriction, they're not getting a lot of fluid, so they're often thirsty and all stuff like that. So a patient on a fluid restriction diet probably wouldn't want the liquid taken from their normal drinks that they would have. So if they still needed supplementation, we can offer Magic Cup, which is like the ice cream texture that I said, and that doesn't count toward liquid. So that would be an instance in where you would choose Magic Cup over a shake, a liquid shake. We do a lot of nutrition focused physical exams, so this is kind of like a growing area in our field. It wasn't always required to do these nutrition focused physical exams, but it's becoming a lot more emphasized now in the field. So with a nutrition focused physical exam, we're screening for nutrition deficiencies. A lot of people don't know, or they think that dietitians don't touch patients, only like doctors and nurses do, but we actually do with this. So during the exam, we're usually taking our hands, we're feeling for muscle and fat loss and wasting. So we'll feel the temporals, the orbital region, the buccal region. We'll look at the shoulders, see if they're squared off, malnutrition. We'll look at the clavicle, see if it's protruding. Again, can show fat and muscle wasting if it is. Not always, but it could. We'll look at the skin, the skin integrity. We'll look at like triceps, the fat under the tricep. We will look at the quads, the calf muscle, the knee. When someone's malnourished, you usually see it in their face first, but the worse it is, you'll see it down their entire body, and it'll be very evident that they have muscle loss and fat loss. The bones will be more protruding, and all stuff like that. And then we can look at the nails, the interosseous muscle, which is when you do the OK sign. It's the little fat or muscle in between the fingers here. And yeah, all those areas we touch, we can tell a lot about muscle wasting and fat loss. So we're doing this assessment on more and more patients. The sooner we do it, the quicker we can put interventions in place, and we can improve on their nutritional status and prevent further weight loss and worsening of their disease state. So it's a real good thing that we're doing it more now. So the last place I interned at, they still used paper charting, which I liked because I'm a paper and pencil person. But this was the first time I'm using an electronic medical record system. So for those of you that don't know, that's basically just in the hospital, you can log on to this site on the internet, and it's all secured. And whether the doctor writes notes, the wound care nurses write notes, the nutritionists or dietitians write notes, nursing notes, any tests that are done, any surgical procedures, physical therapy, occupational therapy, every experience or encounter that any of these people have with a patient, the documentation gets stored in this electronic medical system, and anyone can access it from the hospital. So it's really easy, so you can like kind of put the pieces together and see the whole picture of this patient, whereas if you were in a paper chart, all those like departments would be like categorized and like separated, and you'd have to be like, okay, well on this day you'd have to go to the nutrition record and see what happened on that day. Then you'd have to go find the PT department and see what happened on that day. You'd have to go look in surgeries and see if they got any surgeries that day. Whereas it's all dated in order in the electronic medical records. So it's just easier to read, and all the information's there, and it's a lot more organized and convenient for healthcare professionals to gather all the information about the patient. So that takes a long time to get used to, at least for me it did, but I'm starting to get used to it, and it's really interesting to see all the information that's put in there about the patient. There will be times when your patients don't want to cooperate with you, and family members and stuff like that, so your nurses are the people that you'll go to information for. So it's really important to have good relationships with the nursing staff, people in dietary, and people on the floor, so like the physical therapists, the occupational therapists, even the doctors when they're around. It's really good to just like give your voice, like show your voice, show your presence, and just always have a good relationship with them, because if you don't, and one day you need to go ask them a question, it's going to be pretty hard, and 9 out of 10 times you're going to feel pretty uncomfortable going to them for, you know, if you have a question or anything. So, and also there'll be times where there'll be like miscommunication and stuff, and like I said, the patient may not want to answer you, and the nursing staff may know the answer to your question, so if you have a good relationship with them, you can easily just go ask, and usually they'll know the answer, and you just saved a lot of time by going and asking them. So open communication between you and the nurses and everyone else. So that's basically what I do in a day. I know I talked a lot, there's just a lot to talk about, but yeah, it's a super exciting field. There's a lot to do. What I just talked about today, that's just what a clinical dietitian does, and even other clinical dietitians do a lot of other different things. So like I'm working with renal patients, cancer patients, cardiac patients, diabetes patients, just a lot of different things. But there's also community dietitians, there's food service dietitians, there's dietitians who do outpatient counseling, dietitians who specialize in a lot of different other areas, dietitians that work in schools. There's a ton of other areas for dietitians. So just because I talked about clinical, that may not be really interesting to you, but there's just a lot to cover regarding it, so I figured talk about it in this video just so you can get the most bang for your buck while watching this video, and the most information that you can get basically about what a typical dietitian does in a day. I hope you enjoyed the video. If you have any questions, feel free to message me and I'll answer to the best of my ability. But yeah, I will be coming at you soon with a workout video, and have a Merry Christmas if I don't have a new video up by then. And yeah, I'll talk to you guys later. Thanks for watching. Bye.